Hey y'all, welcome back. I wanted to spend a little bit of time with y'all talking through the depressive and related disorders class. We've covered sort of the basics of a major depressive episode, major depressive disorder, dysthymia, and persistent depressive disorder in the primary video for this module about just the overview of clinical mood states. In the depressive class, there are a couple of other relatively new diagnoses, classifications that warrant further attention. The first is disruptive mood dysregulation disorder. We're actually going to take a look through a case example of DMDD together in this video. The other is premenstrual dysphoric disorder, which deserves attention just because of the controversy related to it. So as you go through this class and you read about PMDD, you'll find that it is, if we're looking at it diplomatically, it is an attempt to recognize that premenstrual symptoms of what's more commonly known as premenstrual syndrome, or PMS, which of course is not a diagnosis, either the DSM-5 TR, DSM-5, or the ICD-11 or 10. PMDD is an attempt to acknowledge that these symptoms of premenstrual, or I guess I should say just premenstrual symptoms, can rise to a level of severity that interfere with functioning in a clinically significant way. It is controversial for a couple of reasons. So this diagnosis first showed up in the DSM-5 in 2013. And on the one hand, it was advocated for by patients, psychiatrists, and the pharmaceutical industry. And on the other hand, it was criticized by psychologists and generalists, fearing over the overdiagnosis and pathologization of relatively normal responses to hormonal changes through the menstrual cycle. Among the opponents were feminist scholars who saw PMDD as a way of silencing women, as an inappropriate categorization of aspects of ordinary life, essentially calling these aspects of ordinary life a mental disorder. Some argued that the diagnosis of PMDD might be used against women to serve to mask the actual reasons for a woman's rightful anger and distress. There was controversy around the fact that the pharmaceutical industry was sort of pushing the inclusion of PMDD in the DSM-5. A pharmaceutical company funded and participated in a consensus meeting on the definition of PMDD. This allegedly helped convince the FDA of the diagnostic validity of PMDD, and consequently led to the approval of antidepressants for the treatment of the disorder, thereby opening $1 million market. So to make the drug more attractive for women, it was repainted in lavender and pink, and the trade name was changed from Prozac to Seraphim as part of the marketing process. The company created awareness campaigns for the condition using the slogan, "Think it's PMS, it could be PMDD." And this is a campaign that was later criticized by the FDA for trivializing the condition. So as you are reading through the depressive class, just know that PMDD is highly controversial. And it seems as though you are unlikely to encounter premenstrual symptoms at a level that rises to meet diagnostic criteria, depending on the setting in which you work. Most of us are going to be working in outpatient settings. It's possible you might see this represented more frequently in acute settings. That being said, be careful to avoid pathologizing what is a relatively normal, if unfortunate, part of being born female. So all that to say, I have a strong sort of sense of skepticism about that diagnosis. On the other hand, the diagnosis of disruptive mood dysregulation disorder has been more or less welcome, especially by those who were critics of sort of a trend of diagnosing young people with bipolar disorder. I mentioned this a little bit in the overview video. One of the things that is complicated about mood disorders is that in our common discourse, including clinical professionals, lay people, and especially marketing campaigns, it is an easy bucket to step in to conflate emotional dysregulation with mood dysregulation. DMDD, for many, it has been a welcome attempt to combine what is a real phenomenon for children and adolescents, to have mood symptoms associated with big and oftentimes disruptive emotional swings, while also ensuring that a diagnosis of bipolar disorder, which is possible, albeit rare, in children and adolescents, that diagnosis still must meet the duration criteria of meeting elevated, expansive, and/or irritable mood, 3 to 4 symptoms for at least 7 days or more for a manic episode associated with bipolar 1, or 3 to 4 symptoms of an elevated, expansive, or irritable mood between 4 to 6 days for a hypomanic episode, which is associated, of course, with bipolar 2. DMDD is perhaps confusingly part of the depressive class of disorders, because it is addressing a persistent sort of chronic irritable mood, which, as you'll note in major depressive disorder and persistent depressive disorder, irritability is often a sign of depressed mood in children and adolescents. So I wanted to give an example of what this presentation may look like. And that has been included in the case example of Chad, which I have asked you to read through before watching this video. So if you have not read through the case example in this item in Blackboard, I invite you to pause the video now, read through the case example, and then unpause it, and we'll walk through sort of the case vignette assessment report that I put together for Chad. So please, if you need to read through the case example, pause now, and welcome back. So, all right, we're going to share my screen here with you. And so you will remember from the case example that Chad identifies as a 9-year-old white cisgender boy who lives with his mother and older sister in an urban region of the United States. Chad's elementary school teachers have reported that he demonstrates above average intelligence. He enjoys playing video games and has historically enjoyed sports, particularly playing basketball with his friends and with a maternal uncle. Despite these assets, Chad has had great difficulty functioning at home and at school during the past 2 years. His difficulties are reportedly associated with a pattern of irritability in mood and frequent outbursts of anger and defiance through verbal and physical behavior. Chad and his mother were referred for mental health and family counseling by Chad's school counselor, and Chad's mother reported the following information, unless otherwise noted. I want to just take a quick aside and say, this is language that is likely to be very useful for you when you are actually working in a clinical setting, not just a simulation like this is. This is going to save you some typing, so you don't have to say like, specifically who reported everything. Usually it's going to be a parent for a child who makes the report of the bulk of the interview or initial presenting information. And so you can say something to the effect of, the mother, the parent, the guardian, whoever the case may be, provided information unless otherwise noted. That allows you to say, well, the child presented this, or a school counselor presented this, whatever, someone that's knowledgeable about the child's presentation. So anyway, just a quick aside. Now, back to our case vignette. So Chad, in terms of socioeconomic status data, he is the youngest of his mother's 2 children. He has an older sister. I believe her, if I'm not mistaken, her name is Ava. And Chad's mother works at a local dog kennel for the family's main source of income. And secondarily, she works weekend shifts from time to time at a local grocery store. I just wanted you to also remember that in the report, or in the case vignette or case example, Chad's mother also reported that she deals with symptoms of attention deficit hyperactivity disorder, or ADHD. And do what you can to put yourself in the shoes of this mother, who is a single parent, already dealing with her own mental health concerns, particularly ADHD symptoms, and also having her energy and attention split between working multiple jobs. As we're considering, and we'll get into this a little bit later, but as we're considering sort of the etiology and neurobiology of what's going on for Chad, at Chad's age, 9 years old, you're remembering, of course, that from the hand model of the brain, that the automatic functioning centers are pretty well formed at Chad's age. The limbic system is pretty well formed and connected to the brainstem and sort of autonomic functioning centers of the brain at Chad's age. What's not well developed, of course, is the prefrontal cortex, which of course is associated with emotional regulation, perspective taking, empathy, planning ahead, following through plans, all the things that are associated with executive functioning. And so, excuse me, is often the case, well, it really is a biological and developmental imperative that people that are Chad's age, when they are experiencing expected sort of challenges of life, that they need the support of a trusted adult, someone with a fully formed prefrontal cortex, and essentially the best way I think to put it is just kind of borrow the brain of the adult to work on making these connections in the most developmentally appropriate way. So that's kind of gets back to what we remember from our earlier videos that included the attachment behavioral system. You'll remember that to foster secure attachment, a parent needs to be, to the best of their ability, a secure base for exploration of the world for the child, as well as a safe haven to return to for feeling safe, soothed, and making sense of what they're experiencing. That's kind of what this brain borrowing process is referring to. And that's why you hear, you'll see maybe parents at the park and the little child is falling and skinning their knee. The parent may pick up the child, and you may be doing this. Those of you who are parents or have had younger children previously, maybe your children are older at this point. Maybe they have fully formed brains themselves, depending on kind of where you're at in your life. You'll remember picking up your child and saying, "Oh, you fell down, and oh, that looks like it hurt so bad," and like you're kind of narrating and sort of expressing your affect in a way that kind of helps the child know what's going on. Do you understand what's happened? This is not something that you're afraid of. That those are all things that are having a neurological effect on the child to prepare the prefrontal cortex to be as well developed as possible, depending on the developmental stage of the child. So in this context, it seems obvious to me, at least, that under the circumstances, Chad's mother is going to have a nearly impossible job of being as emotionally and physically available as any child would need. And so again, we're talking about sort of environmental factors that may be contributing to a diagnosis that need to be attended to. We can change the environment. We don't necessarily have to require the child to change to the environment. It gets back to the question of who needs to change, the child or the environment. So off my soapbox and back to the case example. So she's working 2 jobs, picking up shifts on the weekend, making it difficult for her to be available, both in terms of physical proximity and emotional availability. And so at this point, Chad is presenting with mood and behavioral dysregulation. Chad spends a great deal of his time isolating himself, and he appears irritable most of the time. That's sort of the depressive feature of his general mood state. He demonstrates aggressive outbursts and an estimated 3 to 5 times per week. You'll note in the criteria that there has to be at least 3 of these sort of outburst type episodes per week to meet criteria. The outbursts occur across at least 2 different settings, 2 of 3 different settings. They happen at home and at school. This pattern began when Chad was about 7 years old. So we have reason to believe that it has been going on for more than a year. Another sort of duration type criteria that's being met. These outbursts often occur when Chad is denied something he wants. For example, a dessert instead of dinner, or to be selected as a line leader at school. Chad's mother reports that when she says no, Chad, quote, flips out, essentially flips his lid, like we talked about previously. And he screams, cries, swears, and uses physical aggression, such as hitting or grabbing, until she gives in to his request. Aside from these outbursts, Chad is persistently irritable and shouts answers to even the simplest questions, and he frequently instigates arguments. These are important notes or important details for differential diagnosis purposes. We'll get to that in a little bit too. So recently at home, Chad became frustrated with his older sister, Ava. When she would not allow him to use the family computer, Chad attacked her and left scratch marks all over her face. At school, teachers have reported that Chad engages in verbal conflicts with authority figures, mainly over his disruptive behavior in class, for example, talking out of turn and defiance. And according to Chad's mother, Chad has been expelled from a previous school for verbally threatening a teacher and suspended from his current school for threatening a classmate. So as you can see here, we are getting into frequency, duration, and severity when we're describing the mood and behavioral dysregulation symptoms. In presenting problem 2, I try to illuminate ways in which the conditions in presenting problem 1 are affecting Chad's social functioning. So he has inhibited social functioning and development. Chad has few friends and often loses friends secondary to his inability to control his temper. Chad's mother reports that he seems to isolate himself from others. For example, his mother reports that Chad used to play basketball with other kids in his neighborhood, but has not done so for about 8 months. Another sort of mood-related sort of symptom to keep in mind, sort of the diminished interest in activities previously enjoyed. Chad's mother reports that his normal after-school routine consists of him, quote, coming home from school every day and storming upstairs. He then plays video games all afternoon and evening and rarely joins the family for dinner. Because of his recurrent temper outbursts, his mother has resorted to leaving Chad in his room for hours. She states that at least I can have some peace and quiet. So again, we're noting that the circumstances and the stressors of Chad's presenting concerns are putting really kind of extending Chad's mother beyond the capacity that she has to give, given that she's working 2 jobs and is a mother of 2 children and is the single parent in a low SES situation. So I'm sure most of you, if not all of you, can maybe have a direct experience that reminds you of, or that Chad's mother's description reminds you of. And others of you, if you don't have that sort of one-to-one experience, will be able to easily empathize with how difficult that would be. And these are topics that will be certainly points of discussion when you are taking your family systems course, as sort of the stressors on a family system serve to kind of maintain problematic emotional, mood, and behavioral conditions for our clients. So this is my description in terms of frequency, duration, and severity of the inhibitions or the impact upon Chad's social functioning, right, which is a necessary component of any clinical mental health diagnosis. In the third presenting concern, I'm bringing up the child equivalent of occupational functioning. So inhibited academic functioning and development. Chad's interpersonal difficulties may help account for his grades, which are lower than would be expected for his intelligence level. Chad's mother states that when she asks him to complete his homework, the assignments, he refuses. These discussions usually result in a verbal altercation, ending with Chad storming into his bedroom. Chad's mother also reports that she suffers from ADHD, as I mentioned before, which sometimes affects her ability to track her son's assignment completion. So we have sort of the conflation of 2 concerns that are exacerbating the child's difficulties. This is something that, that to keep in mind. It's a little bit outside the scope of this course, but this course is the foundational for your treatment planning and techniques courses. So these are things that you want to have in mind when you're thinking about sort of systemic stressors that may be addressed through treatment planning, interventions, and other techniques to alleviate the mental health symptoms. Chad's teachers have scheduled many conferences with his mother because he is underperforming in 3 classes. Teachers have conveyed that to her that Chad has an above average intelligence and should be performing better in these classes. Again, this is going to serve to help out with differential diagnosis. Relevant history. As was reported above, Chad's presenting concerns began when he was 7 years old. Chad's father died when he was a young child, implying that his death occurred prior to Chad's problematic emotional, mood, and behavioral regulation patterns. Okay, so this is the first time we're mentioning Chad's father's death. And so these are things that will be certainly points of consideration for differential diagnosis, and points of consideration for treatment planning when you're considering a case like Chad's in your experiential coursework and your clinical practice after graduation. So Chad rarely, if ever, talks about thoughts or feelings he has or has had that are related to losing his father. No information was reported related to child's cultural history and identity. That is often the case, interestingly, when you have a child who is white and or I guess really regardless of socioeconomic status. One of the chronic sort of conditions and social stressors of Caucasian ethnicity in the United States. That, of course, is a poignant topic for discussion in other courses as well, like your multicultural considerations. No vocational history was reported due to the client's age and developmental level. No medical history of concern was reported. Chad denied having suicidal thoughts. He also denied having symptoms that would indicate experience of a manic episode, psychosis, or substance misuse. Chad is legally considered a minor in the custody of his biological mother. And Chad's mother reported that she suffers from symptoms of attention deficit hyperactivity disorder, which impacts her ability to provide care, guidance, and supervision at times. And of course, these descriptions cover these items in the vignette guide. So in terms of a formal diagnosis, Chad meets criteria for disruptive mood dysregulation disorder. I've also listed as rule outs major depressive disorder and persistent depressive disorder. I'll get into that just a little bit. So my diagnostic rationale. So to this clinician, Chad's pattern of frequent temper outbursts expressed verbally and physically appeared to be notably disproportionate to this reported stimuli, developmentally inappropriate for a 9-year-old, and occur frequently enough, 3 to 5 times per week, to meet criteria A, B, and C of DMDD. His mood, as reported by his mother and teachers, is irritable most of the day between outbursts, meeting criterion D. Criteria A through D have persisted for about 2 years, meeting criterion E. Criteria are met across 3 settings, home, school, and among peers, and meeting criterion F. Chad's symptoms began at age 7, meeting criterion G and H. That's related to, this is diagnosis that should not be considered prior to age 6 and not after age 18. The symptoms need to have emerged prior to the age of 10. So this really is a disorder of childhood that can persist into adolescence. And so just keep that in mind as you're considering this as a diagnosis, especially those of you, and there are several of you who have mentioned that your career goals include focusing your clinical practice on the psychotherapy for young people. So let's see, where was I? Yes, so the symptoms began at age 7, meeting criteria G and H. Manic episodes, psychosis, and substance misuse were ruled out by the diagnostic interviewer. I'm sort of assuming that there was a diagnostic interviewer given that we have this information. This meets criteria I and K, and the symptoms do not appear to be better explained by another disorder, as will be detailed in the subsequent section, meeting criterion J. So other diagnoses considered in differential diagnosis were ADHD, major depressive disorder, persistent depressive disorder, intermittent explosive disorder, which we have not yet covered, oppositional defiant disorder, which again, we have not yet covered. I could also add in here perhaps intellectual disability, because we can rule that out because of the general sense of educational experts, teachers, school counselors, and other educational personnel who have indicated that Chad is of above average intelligence. it might do the family good to have Chad's intelligence assessed in a more formal way. That might open some doors to supporting his sense of self-efficacy. And what, you know, a sense of a improved sense of self-efficacy typically can serve as an antidote to depressive symptoms. All right, so ADHD was considered given Chad's mother's report of her own diagnosis. Chad's reported tendency to blurt out responses to questions and difficulty waiting his turn, and the high correlation between DMDD and ADHD presentations. You'll read about that in the differential diagnosis section of your DSM-5 TR. However, Chad does not appear to have difficulty attending tasks. For example, he has no trouble focusing for long periods of time on video games, he does not appear to have difficulty attending the tasks or enough other criteria to meet diagnostic standard of ADHD. IED and ODD were ruled out because although the behavioral expression could meet criteria for both, the persistently irritable mood symptoms are not indicated in IED or ODD according to the DSM-5 TR. Finally, MDD and PDD remain under consideration because although there is insufficient information in the initial report to meet criteria for this condition, these conditions, further investigation may reveal other qualifying symptoms beyond depressed, irritable mood and diminished interest. So see the loss of interest in basketball with friends. It's also important to note that this also could be closely related to bereavement or sort of unresolved bereavement, which also has its own considerations in the DSM-5 TR. We just don't have sufficient information to further explore that. And the mood and behavioral symptoms seem to be so severe as to be better accounted for by a diagnosis like DMDD. Now, neurological and biological considerations, including psychopharmacology. A brief review of the literature suggested that the etiology of DMDD is similar to the MDD and bipolar disorders and may be exacerbated by difficulties for emotional availability and support of one or more custodial parents. Antipsychotic and mood stabilizing medications, for example, risperidone and lithium respectively, are the most commonly used to treat DMDD. However, in the absence of psychotic or manic symptoms, a combination of family and cognitive behavioral based psychotherapy and mild doses of a SSRI may be best indicated for Chad given his concerns based in depressed mood and stressors on the family system. Stimulants, which have also been used to treat DMDD, are likely not indicated for Chad's case due to the propensity to exacerbate agitation and restlessness. So that was sort of my impressions of Chad working through the vignette initial assessment report. I'm looking forward to hearing back from you about comments, points of clarity, questions you may have about DMDD and other depressive and bipolar related disorders in the discussion board for this module. I look forward to seeing you in subsequent videos, and I'll also look forward to seeing the work that you're going to put together in your wiki groups for this module. I'll see you in at the next spot. Thanks.